Hello and welcome to this PCR webinar on the essential topic of TAVI in patients with bicuspid aortic valve disease. My name is Bernard Prendergast. I'm an interventional cardiologist from London, UK, and I'm joined today by my friends and colleagues from Europe, Markus Castle from Zurich, Switzerland, and Won Kim from Bad Nauheim in Germany. Welcome to you both.
Thank you.
So bicuspid aortic valve disease is something we've been familiar with as clinicians for a long time, but only in the last few years has it begun to really enter our mindset as interventional cardiologists. And Markus, have you noticed, perhaps in the last 5 years, that you're seeing more patients with this pattern of anatomy coming forward for treatment?
Yes, I think a clear yes. We see more and more patients coming with a bicuspid valve, and that's the reason is that we treat more younger patients now who have more higher incidence of bicuspid valves. And in the mid of this year, I made a move from Germany to Switzerland, and what I realized there are differences in between the countries. So I think we see much more bicuspid in Switzerland than what I have seen in Germany.
So that's an interesting observation from your own personal transition from one country to another. Also, I've been involved with colleagues in Asia, particularly in China, where they see a huge amount of bicuspid aortic valve disease, perhaps as perhaps almost a different pathophysiology, but also reflecting the fact that they also treat younger patients by virtue of their shorter life expectancy in those countries. So there's no doubt that this is coming our way as a major treatment need. And as we think about the challenge of these patients, is it just like doing a plain old TAVI, or is bicuspid aortic valve disease different?
Yeah, I have to answer this question with yes and no. Yes, because it really depends on the phenotype that you are confronted with. And you have to be aware of the fact that patients with bicuspid aortic valve can have a huge variety of different anatomic phenotypes. And there might be patients which are very similar to tricuspid aortic valves, and these patients can be treated like tricuspid aortic valves. There is no big difference in such patients, whereas we are all aware of the very complex anatomies due to the calcification, due to the fusion of the leaflets that can be very challenging. And in our institution, actually patients with bicuspid aortic valves are treated by the more experienced operators.
Okay, so there clearly are important differences when it comes to the planning of the procedure and the performance of the procedure. Yeah. And of course, the better you plan and the better you perform, the better the outcomes for our patients, which is a key element. So on that note, it's important and interesting to note that these points that we've raised are highlighted in the objectives of this seminar, where we hope to learn more about the challenges of TAVI in this particular anatomical subset. And we're going to learn how the use of advanced imaging, particularly CT, is essential to understand the anatomical configuration of the valve and how that anatomy impacts on the choice of device, critically on the sizing of the device, and as we will hear from Markus, on how we position the valve accurately to obtain the best clinical outcomes. And we will be talking in a lot of detail about how we achieve optimal positioning to reduce, for example, paravalvular leak, or how to avoid obstruction to the coronary arteries, which are key elements in this discussion. So as we think about bicuspid aortic valve disease as clinicians, we need to reflect on the fact that, firstly, it is the most common anatomical variation, affecting 1% of the population in many post-mortem anatomical series. And it's important because bicuspid valves degenerate more rapidly than their tri-leaflet counterparts. So for that reason, patients presenting with complications of their disease are often younger, in the 6th or 7th decades of life, far younger than the patients we are currently conventionally treating with TAVI. We also need to remember as clinicians that bicuspid aortic valve is associated with many other anatomical variations in the cardiovascular system. There is frequent associated aortopathy with dilatation of the aorta, which can be a precursor to dissection. There is an association with anomalies of the coronary anatomy and left main stem aneurysm. There is an association with aortic coarctation and mitral valve prolapse, frequently seen in much younger patients. And we mustn't overlook the fact that there is a genetic association in subjects with the Marfan syndrome. When we think about the challenges of the anatomy in relation to intervention, we need to remember that the aorta is frequently aneurysmal and tortuous, which may have impact on our delivery technologies. That the valve orifice is frequently oval or non-circular, so sizing the valve can be challenging and difficult, and we'll be discussing that in some detail. There may be implications for the selection of the particular device, and we'll be discussing that in detail, comparing balloon expandable versus self-expanding or alternative technologies. And in selecting the best device and obtaining the best outcome, we of course aim to avoid the complication of significant paravalvular leak, to enable future coronary access should it be required in particular patients, and hopefully ensure a durable result in terms of the hemodynamic performance of the valve itself. Now, 2019 has been labelled as a leap year for heart valve disease and for intervention in heart valve disease, and that's partly because of the publication of the low-risk trials in TAVI earlier this year, when we were able to observe that in comparison with surgical counterparts, transcatheter technology was associated with vastly superior outcomes, particularly when you bear in mind the patient experience associated with a short hospital stay and a very quick recovery. But we do need to remember as interventional cardiologists that bicuspid valves were specifically excluded from these studies. So whilst we may feel there is a mandate to treat younger and lower risk patients with TAVI versus surgical aortic valve replacement, we need to remember that that evidence base does not extend to patients with bicuspid aortic valve anatomy. And that, of course, is a very real issue because, as you can see on this slide, the prevalence of bicuspid aortic valve disease varies directly as a function of age. And you can see that the peak decades of the frequency or the prevalence of bicuspid aortic valve disease lie between the age of 50 and 79, which is largely the cohort in whom TAVI is not universally applied in the current era. So that provides our background, and now maybe we should move on to discuss some specific features. But before we do so, I need to remind you that this is an interactive webinar, and it's very important to us that you transmit your questions at any stage during the webinar so that we can interrupt our discussion, we can pause on our slides, and we can accommodate your questions and address them in detail, because that's the whole purpose of this interactive webinar facility. So whilst those questions come through I think it would be very helpful for us now to turn to the question of anatomy, diagnosis, measurements, these very specific features which imaging can only provide for us.
Yeah, I would like to start with the classification of bicuspid aortic valves. I think everybody is familiar with the classification by CVAS, which differentiates between type 0, type 1, type 2. Type 0 is quite clear, it's bicommissural, it's non-Raphe-Type, Raphe-Type. Type 1 is the type that we encounter most frequently. And type 2 actually is extremely rare. And actually, the CVAS classification is not very helpful for our daily practice. And there's another classification by TAVI. It is more imaging-based, CT imaging-based, which also discriminates between bicommissural and tricommissural aortic valve, and takes more into account different phenotypes within type 1. So tricommissural can have a complete Raphe and an incomplete Raphe. And what is important to know or take into account is that if you see a tricommissural aortic valve, it is frequently being referred to as acquired or functional, or tricuspid aortic valve with fused leaflets. So they're suggesting that this could be a postnatal phenomenon, but actually most of these entities are congenital. This has to be in our minds, and this, of course, also leads in the diagnosis to a misleading diagnosis of thinking that we have a tricuspid aortic valve.
Yeah. And these terminologies, they're often used rather interchangeably, which can cause some confusion, for all of us. And a more precise wording would be very helpful.
Exactly.
You could even say that this is a distinction between an anatomical classification, the Sievers classification, and a more practical interventional classification based upon the different modes of fusion. And does this translate, Marcus, into sort of clinical differences or your approaches as an interventionist?
I think clinically important, in my opinion, is to differentiate in between Raphe-Type and Non-Raphe-Type, whereas Non-Raphe-Type is anatomically very different, has only two cusps on the one side. And the other side, you have the Raphe-Type, who is anatomically a bit similar to tricuspid valves. But it has a Raphe which can be calcified and has an impact on our decision-making, what valve type and how we deploy it.
So this distinction with what you see on, for example, the CT scans here is very important for you when it comes to planning your approach and the actual performance of the procedure.
Yes. So we make a bit different procedure planning, and I think also the difficulties are different in both types.
Okay. And we've got a question here from our participants already, which is which classification should we be using in clinical practice? Because we've all learnt the Sievers as medical students and as cardiologists in training, but which one should be used when we're communicating with each other?
Yeah. Actually, in our clinical practice, we use the Sievers classification, being aware of the fact that it is not very helpful in clinical decision. It does not discriminate between which valve we will use or which therapy concept we will be applying. And it is more important to look at the anatomy in detail, to look at the length of the Raphe and the degree and distribution of the calcification. This is much more important and should be taken into account for future classification. And to the best of my knowledge, Hassan Jalaivi is working on a revised classification to take these aspects more into account.
Well, that will be very helpful in terms of our communication with each other, won't it? But meanwhile, I think we should stick to the metaphor of just talking about what we see and what we're describing.
Exactly.
Marcus, just quickly before we move on, one of our participants wants to know whether there are any ongoing trials which are actually enrolling bicuspid patients at the moment.
So, it's there are trials planned also from our center, but enrolling beside registries, I don't know specific enrolling trials at the moment.
Yeah, I'm wondering in my mind about the Notion 2 trial, but I'm not quite sure.
Yeah, so I'm not sure that I'm not sure.
Okay, so I think the answer is that it's a watch this space. There are trials being planned, but we need to bear in mind that we won't have the results of those for some years. So meanwhile, we've got to get on with the knowledge that we have already. Yep. So Juan, tell us a little bit more about diagnosis of bicuspid aortic valve disease and how imaging is of such fundamental importance.
Regarding diagnosis, I just want to emphasize that it is really important, especially if you want to treat patients with TAVI, to at first hand recognize that there is a bicuspid aortic valve. And we analyzed that in our institution. We worked up all echo reports and found that from all TAVI cases that had been performed, only 10% of patients with bicuspid aortic valves had been recognized by routine echo using transthoracic and in some cases transesophageal echo. And of course, we all know that sensitivity of transthoracic echo is limited due to the lower resolution. TEE is better in its sensitivity, but this applies especially for patients which have been examined in studies and with lower amounts of calcification. If you if you look at contemporary TAVI populations, you will have elderly patients with much more calcification. So it will be really difficult to tell for the echo operator whether there is a tricuspid or bicuspid aortic valve. And in this context, it becomes extremely important to have a CT analysis, and sensitivity using CT increases up to 95%. And if you use CT, it will be important to take into account also systolic reconstructions where the bicuspid phenotypes can be appreciated much better than if you only have diastolic reconstructions.
And should these CTs be done in the hands of cardiologists, in the hands of radiologists? Does it matter?
It should be someone who is aware of the classification and of the different phenotypes of the bicuspid aortic valve. With type 0, no one will have a problem to recognize it's the bicuspid aortic valve.
Sure.
Type 1 becomes much more difficult if you look at the different lengths of a Raphe, etc., and if there's a lot of calcification. So it should be someone with experience in this category.
Okay. And of course, most patients who've been considered for a CT in 2019, 2020 are going to have a CT scan. But just for completeness, does cardiac magnetic resonance help us in diagnosis?
The resolution of CMR depends also which kind of generation scanner you have. 3 Tesla scanner will be much better than 1.5, but usually it is easier to recognize bicuspid anatomy with CT because of the calcification.
With the calcium, exactly. Yeah. And as we shall see, calcium is a particularly important consideration when it comes to assessing these patients. So we've talked about diagnosis, and we've talked about how we distinguish the different anatomies and the improved sensitivity of CT compared with echo. What about using CT for sizing? Because choosing the size of the device is so critically important, and this is another confusing area for many people. So give us a simple guide as to how we use the CT scan to measure our devices.
Yeah. A simple guide is difficult. We all are, we all know that annular sizing using 3D CT is the standard of care for sizing prior to TAVI. This is, there's no discussion. We have data that we can improve results substantially if we do that. So for tricuspid aortic valve, this is the standard of care. Regarding bicuspid aortic valves, there is a controversy, and there is an alternative method of sizing, which is supra-annular sizing, which came up due to the fact that there has been a narrowing, which is a very narrow part, around 4 to 8 millimeter above the annular plane, and I think Didier Tietche has done some analysis on that. And the goal is to estimate the aortic orifice using either the perimeter or the intercommissural distance at various heights. So 4 millimeters seems to be the most appropriate, but there is no consistent recommendation on how to do it, which tool to use, and there is only little data about it.
And it's difficult, isn't it? You know, it needs the hands of experienced, or the eyes of experienced operators to reproduce these measurements.
Exactly.
And it may be that you need to do multiple different methods and arrive at some kind of consensus measurement. Marcus, I think you're a proponent of annular measurement, and supra-annular maybe you're not quite so sure of its value.
When I'm honest, I never really understood the real concept behind this, and so it is. I think this measurement is very subjective, and I think we need something for daily practice and not too much values who are misleading. In my opinion, we need one sizing object, and in my opinion, it's also in bicuspid, like in tricuspid valves, it's the annulus sizing, and my treatments I do based on annular sizing.
Okay, and just come back to this point about the 4 millimeters one, because I think that derives because the shape of the valve is a bit like the shape of a volcano.
Yep.
And 4 millimeters is an important point for some anatomical reason. Can you just clarify that for us?
I think the DHHA, they found that they measured different levels of at the
so from
supra-annular
0.0 maybe up to
and then
12
they found
or
that the most narrowing is found around 4 millimeters.
Okay.
I don't know. I don't think it must be exactly 4 millimeters. I think a measurement around 4 to 5 millimeters is appropriate.
Okay.
And
so we're talking quite a lot about the annular diameter, but there are other features that we need to bear in mind. So the height of the coronary ostia, any associated aortopathy. Is there anything you want to add on those topics?
Usually, patients with bicuspid aortic valve have large aortic root anatomies. So, of course, there is always a concern of having coronary compromise when implanting a TAVI device. But if you have, even though you have a relatively short vertical distance to the coronary ostia, if you have a wide sinus, you will usually have no problem with coronary obstruction. Yeah. And of course, you have to be careful also in regard to device selection. Aortopathies are frequently encountered pathology in patients with bicuspid aortic valve, and also have to be taken into account when decision making.
No, and we'll come on to that presently when we talk about choice of devices and choices of strategy. Marcus, what about the issue of leaflet length and leaflet calcification? Thinking now about the very dangerous complication of coronary obstruction, is that something else that you take into account?
I think you have to take it into account, but not only leaflet length and calcification, but also the width of the sinus. When you have enough space in the sinus, then it's less a problem. And also the height of the coronaries when they are very far from the annulus, the risk is less than when they are very close. So there are a lot of factors you have to take into account. And sometimes balloon sizing shows you what happens with the calcification, where you push it, perhaps. So we add additional tools to figure it out.
And just as an estimate, what proportion of patients in your practice are you actually protecting the coronaries these days?
So protecting coronaries, that's another topic. I don't think we don't offer them a good protection. When you think about placing a wire or balloon or a stent into the coronaries, some patients we cause trouble with this technique.
Yeah, for sure.
And it is at the end, perhaps you can reopen a closed coronary, but it's never a good treatment.
No, sure.
Because the Chemney technique, when you want to get back to the coronaries one day after your valve implantation, it will be very dangerous, and that cannot be our
So we need to remember that coronary obstruction is a life-threatening complication, and without a good solution. So it's one that we need to predict and
there are solutions like basilica technique to cut leaflets. Perhaps this will be a solution for some of these valves. You can do it also in native valves, also in bicuspid valves. So there are perhaps some other solutions in the future.
Before we move on, sorry to go backwards, but one of our participants wants just a bit of clarification about this intercommissural distance. They particularly mentioned the Bavard registry, which is what we were discussing, Didier Chetjet's work.
Exactly.
But can you just use the slide again just to clarify this intercommissural distance measurement?
Maybe if you look at the slide and the lower image, in panel A, there is an image. There is an example of measuring the intercommissural distance. So it's the distance between the commissures at 4 millimeters. Of course, you don't see the end of the commissures because at 4 millimeters, you don't see the end of the commissures. But I think, as already mentioned, there is no consistent final recommendation on how to measure it, on which place exactly to measure, and where I'm also not sure whether 4 millimeter is the final solution of taking the complex anatomy into account.
So how do you handle this in your own practice? Because there's lots of different measurements, and when none of us are entirely sure which one is the best. What do we do in real life?
Due to this controversy, we made an analysis of our single center experience with treating bicuspid aortic valves, and all these patients have been measured with by annular sizing, and we compared it to measuring the intercommissural distance 4 millimeter above the annulus. And the main finding, which is not shown here in the image, is that with annular sizing, we had good outcomes in the vast majority of patients. So using second-generation devices, we had good outcomes. There was high device success, and there were only a few patients where we could have, where supra-annular sizing would have been useful, and you can see it on the slide. When you compare a supra-annular measurement, there would have been a different size selection in around 40% of cases. 40% of cases. And given the good results that we had with annular sizing in most patients, a different size selection probably would have led to a worse outcome.
Okay.
That's what we assume. And Didier Cheche has put it in a similar way, actually. He is recommending annular sizing in the majority of patients. In some few patients, it might be advisable to take into account supra-annular measurements, especially if you have borderline situations.
Okay. So I think the message is that there are a variety of different ways of measuring the annulus, that the data supporting them all in competition with each other is a little bit limited.
It's very limited. It's
and
only
we really need
data.
to stick to the modes of measurement that we're most used to, so that we become familiar with our own sizing algorithms in our own individual practice.
Yeah.
Okay, so let's turn now to device selection, because again, these measurements and these characteristics of the valve and its associated anatomical structures are fundamentally important for device selection.
If you deal with bicuspid aortic valves, you will have a wide variety of different phenotypes. And you can have, as shown in the slide on the left-hand panel, very straightforward anatomies, which I would call tricuspid aortic valve-like anatomies. These patients have good access, no tortuous anatomy, mild to moderate calcification, and in my mind, probably can be treated with any new generation device. So there's a lack of data in regard to differential treatment using especially second generation devices. There are a few registries that are coming up, but so this is my personal opinion. If you go to more challenging anatomies, and this could be either tortuous or horizontal aorta, which is frequently associated with bicuspid aortic valve, it may be useful to have more flexible delivery systems and systems with a more controlled deployment. And even though we all know that the transapical axis has a worse outcome in most patients, in this subset it might be beneficial. At least you should take it into consideration.
Yeah.
And if it goes, we go further to more complex aortic root anatomies with calcification, severe calcification, very irregular calcification, or even large anatomies, then I think there's a need for high radial force, and especially a sealing skirt. The special thing about a sealing skirt is that you may have a slight under-expansion of the valve, and the sealing skirt will cover the rest of to prevent PVL. So if you look at these examples, of course, we have to ask ourselves whether all anatomies are appropriate for this interventional treatment. And so I think it is my opinion that we should keep in mind that there's also a conventional surgery for these patients, especially in extremely calcified anatomies.
Absolutely, and just focusing on the TAVI algorithm at the moment with the different devices that we have available, Marcus, what do you think are the relative pros and cons of, let's say, balloon expandable versus self-expanding versus retrievable systems in the bicuspid aortic valve anatomy?
So what I think here, one key point is the amount of calcification and the use of self-expanding or balloon expanding. So in my experience, most bicuspid valves, they are highly calcified, and here you are more to the right side, complex root anatomy, and here you need a valve where who is able to push all the calcification beside. Otherwise, the result will not be good. So, so a simple answer: it depends more or less on the amount of calcification.
Okay. And the trade-off that you're alluding to is the high risk of paravalve leak if you don't push the calcium aside. Equally, a slightly increased risk of annular rupture when you use balloon expanding technologies.
That's the bad side of the calcification. That here annular injury is more common, but you know this also. That doesn't matter if you use also a self-expanding valve. You have to open the valve beforehand, and you have to do a pre-ballooning at least to find some space for the self-expanding valve, and also this has a risk. And,
and the mechanically expanding Lotus valve is now back on the market after a period of time without us being able to use it. Do you think it will have particular advantages in this anatomy?
Yes, we know it has a good sealing, and this is very important, and it has a strong frame and a strong radial force. But it's a very bulky valve, and on the other hand, we treat more and more younger patients. We want to have access still to the coronary arteries. Perhaps we get into conflict when we use Lotus valve for this. But I have a very limited experience with this.
Okay. It's worth mentioning as well that our colleagues in China have been developing their own independent valve programs, and the valves that they use, self-expanding valves that they're using in China, have extremely strong radial force because they encounter very heavily calcified bulky valve leaflets. So these particular devices for particular anatomy and particular geographies are maybe something that we will see coming through to Western experience in forthcoming years. Who knows?
Maybe one more comment regarding these extremely calcified anatomies. I think, as a matter of fact, in most patients, even with very heavily calcified anatomies, with new generation devices, currently we are able to achieve good outcomes. Good acute outcomes. So PVL rate, there will be some with moderate regurgitation, but in most of these patients, we will have good acute outcomes. But what we have to think of is the durability of these patients. Yeah. I think stent expansion will not be even, and we have to think about long-term consequences in these patients. Yeah.
And as you mentioned earlier, we mustn't forget, particularly as we start to treat younger patients, that sometimes surgery may well be the best option. If there's a very heavily calcified valve, a higher risk than usual of coronary obstruction, then there's no shame in asking a surgeon to offer a surgical alternative to TAVI if the patient would do well both in the short term in terms of their hospital recovery and getting out of the OR, and in the longer term in terms of the durability of the device that the surgeon would use. And that's particularly relevant, of course, when we start to talk about patients with associated anatomy. So here's a nice image, a volume rendered CT image of a patient with a relatively large ascending aortic aneurysm. And we can't deal with that by means of TAVI. So we need to remember that the surgeons have expertise beyond that interventional cardiologists can offer. And the same is true if you have a heavily calcified bicuspid valve and very complex coronary artery disease. It may well be that the surgeon will do a better overall job that even the most skilled interventional cardiologist can achieve. So we need to remember that as well. So moving forward, we've talked about lots of theoretical considerations in terms of diagnosis, planning, device selection, and so forth, but it would be very interesting to look at some cases, Marcus, and perhaps see how you translate this pre-procedural planning into the performance of a procedure. So perhaps you could take us through one case in detail, and then we could talk about some of the variations thereafter.
In fact, I have 3 cases to show you, and let's start with the Non-Raphe-Type type 0 bicuspid aortic valve, as it is shown here. It is a valve, you see the CT with 2 cusps, and here it's moderate calcification, and what we see is a calcification also, it is symmetrically at both sides of the valve. Sometimes we see, and that brings us in problems, we see only at one side calcification and not at the other side, or we have a lot of calcification here. In this case, it's moderate, so more uncommon. But it's a very big annulus measurement, more than 29, and we see this also often, that we deal more often with bigger anatomies. And when you look at the root chart here, oh, yes, it's coming. We see the valve has only 2 inch points. So how to align a root when it has only 2 inch points? So our root chart and a coplanar view can fail, and we have to deal with this also. In most, nearly in all cases, I do balloon sizing, and here in this case I knew that it was a 29 valve, and even we added more volume in this 29 valve. But in all cases we make sure that not the smaller valve, so here in this case a 26 would be the better choice. So we use a 25 balloon here, if it's in the Edwards set. We give contrast, and this balloon sizing gives us a lot of information. So what we see first is the balloon stays in the middle, shifts not to one side, and sometimes impact of calcification could be that, especially when it is asymmetric, that the balloon and also the valve shifts to a weaker side and can cause there an injury. And we also, with the balloon, we see there is no influence to the coronary arteries. And so it gives us some ideas what is the impact of the calcification and how is the anatomy. And here we decided for a 29 sapien valve, and we added 2 additional milliliters, what makes the valve frame around about 1 millimeter in diameter bigger. And we implant the valve very high. We do it, we like this in bicuspid valve, a high implantation, and we learned that the sealing is very good. We cover all the long leaflets behind the valve frame, and also we saw a low pacemaker rate. And here you see the result. The valve is very high implanted and has a good functional result here, also with a lot of contrast, giving into the root. And on the right side, then we see also in a post-CT that the valve is fully deployed round, and also at the inflow it became a bit bigger because of the additional volume. So when we look in detail, the same case now, once again the implantation view, we have only 2 inch points, and we have to deal with this, and we cannot 100% believe the implantation view. I'll tell you how we do it later.
That's exactly what I was going to ask you, because the CT scan tells us which imaging plane to use.
The predicted view based on the CT is, so measurement in a CT with 2-inch points, the alignment is difficult. And most of us, we use Tremensio software. It's based on a centerline analysis, but it could be misleading. And what we learned is that often annulus size is overestimated. We published also a sizing paper. I mentioned this.
Is that the slide that we
That was
skipped? Should we quickly go back to that slide?
I can describe it. It is so we need 3-inch points to three-dimensionally align an annulus, but we have only 2. So what we do, we align the 2-inch points, and then we rotate around the 2-inch points, and we make multiple measurements, and the smallest measurement, annulus measurement, what we get, we use for our valve choice. And so here also in panel B, valve crossing could be a problem in a big anatomy. Sometimes we use an AL2 instead of an AL1 catheter. There are different techniques. We usually in this big anatomy, I try to start with wiring the left, and then I pull back the catheter, and it comes then goes from left to the non-coronary side. And on the way, we will cross the valve opening usually in the commissure.
So you map the anatomy as you manipulate the catheter millimeter by millimeter.
Yeah. And I do it in type 0, but also in type 1. We know where the Raphe is. And so don't try to cross where the Raphe is. That makes no sense, and we know it by CT.
So you've mentioned the AL1 and the AL2, but I think sometimes you use a different selection of catheters, particularly for horizontal aortas.
Yeah, we also start with AL1 and then switch to AL2, especially in large anatomies. But especially in horizontal aortic routes, we have made the experience that using the EBU or XB catheter could be quite useful. The curve,
coronary guide catheter.
Yeah, coronary guide catheter. For those who have not tried, I really recommend, because even as an experienced TAVI operator, it can be challenging to cross the aortic valve in bicuspid anatomies. And if you do not get along with standard catheters, AL1, AL2, it might be an option to try EBU 3.5 or 3.75.
The problem in this anatomy often is that we cannot come high enough to the left side. And so, but you can manage this also with the AL2. How to manage? Bring the AL2 all the way in. It will go towards the left main. And then once the AL1 is placed, AL2 is placed in the left cusp, then place the wire and pull it back, and then you can come also from left to the non-side. So there are some tips and tricks.
Yep.
I mentioned balloon sizing. We do it in most cases. And then once back to the implantation view, in D we show how we align in addition the valve itself. So look that the valve frame is aligned. This is also used by core valve. We have the ring, we align the ring. It's the same we can do with the sapien valve. And when we want to get in a high position, bring the central marker at least 3 millimeter, that's 1 central marker length above the line in between the 2-inch points. And
so this is the red line on our slide.
That's the red line on our slide. And then E and F, panel E and F shows you the implantation result. It's close to 100% aortic, but we see we have the knowledge that we can get to a good result in this position.
Can I just take you back a little bit to the balloon sizing, Marcus, because we've got some specific questions from our audience about that. So are you using, what's the ratio to your annular measurement? Which size balloon do you select? That's my first question.
So it is, with balloon sizing, I use the size of the balloon of the smaller valve of choice. Okay. So that means, for example, here, more or less it was a 29 valve, but sometimes we have a measurement, for example, of 27, let's say 27. Then a 25, we use a 25 balloon out of the Edwards kit because it's free. It's also very useful, or you can also take a 26 balloon, and we make sure that not the smaller valve of choice is the valve what we what is the better, what has the better size, and the balloon clearly will show us this.
Okay, so you're demonstrating the balloon at full expansion, how close it comes to the walls of the aorta and the sinuses.
So we see the 2-inch points of the here in this case of the left and the non-cusp. So when the balloon touches clearly the 2-inch points, then it's a major criteria that the balloon size, the valve size could be the same than the balloon size.
Okay.
And so when this, like here, the balloon is much smaller and it does not touch the inch points, then there's no way to use the smaller valve.
And are you routinely looking at what happens to the valve leaflets and the flow in the corollaries?
So because you don't have the, when you choose now the bigger valve, you don't see the complete reality. But you see how much material is in the valve and you see in which direction you push it. And you have an idea what can happen when you use the bigger valve in this case. And one thing very important is really, we have to. I looked that the balloon is really stays in the middle of the valve and is not shifted to one side. And it's especially in Raphe-Type, it could be when you have a very stiff Raphe that the balloon is shifted to the other side. And when there's no calcification, for example, then you can make an injury.
Okay.
Because,
and given that balloon sizing or pre-dilatation is an extra step, do you routinely use cerebral protection? Do you think it increases the risk of a stroke?
In our experience, because we did it in the past, very often we pre-ballooned the valves, and I do it with self-expanding valves. My opinion is we have to prepare the valve, and that's a self-expanding valve can fully deploy and that you can place it precise. There are other opinions about this, but it's my opinion. So we have a long experience with this, and when we compare our data with the published data, we don't cause more strokes with this.
Okay, and that's reassuring. And one, I know you've had a lot of experience with the Boston Accurate valve. Would you have the same practice week to week, day to day?
The Boston Accurate valve, you have to be aware that it has much lower radial force. So pre-dilatation in most anatomies is mandatory, except for mildly calcified patients. But I think this is a very good question, Bernard, because Raj Makar recently published a study on bicuspid aortic valves using the S3 in a large population based on the TVT registry, I think. And they found that there is a higher rate of stroke in patients with bicuspid aortic valve. So
I saw this in our collective also. So it has.
So I think there is a big question mark.
Something that we need to all be thinking about.
Exactly.
Absolutely.
Especially when we have younger patients, then perhaps in this cases we have to use cerebral protection.
So Marcus, you've talked us through a non-Raphe case.
Yes.
Let's move now to a case with a Raphe.
Yes, so that's the next case, and okay.
Could we advance the slide, please?
It's frozen. Oh yeah.
Good.
Okay. So here it's a typical case with a Raphe in between. Here you can see it also in a root shot. It is in between non and right cusp, and then there's a bigger gap to the left cusp, and there's an arrow shows where the opening of the valve is. And this is also has an impact where you try with your wire. Don't try to cross in between non and right here. And this information you get from the CT. Balloon sizing here in this case, it was a 23 balloon. It touches clear the inch points. 23 valve was the valve of choice. And as there was a lot of calcification, we were careful, and I'm often more careful with, I'm always careful, but more careful with bicuspid when there's a lot of calcification. So we deployed here also the sapien two steps. So we under-deployed it first with -2 milliliters. That makes the valve more compliant. As you see here in the non-coronary side, the valve frame is not complete straightened, and it gives a better way out for the calcification. But we saw here that there was still paravalvular leak, and then in a second step, we postulated it nominal. We straightened the valve frame better, as you see. We could achieve a better result. And also, I think perhaps when you do it stepwise and you give not all the pressure in a short time on the tissue, when you do it in two steps, perhaps it has also makes it safer. Tissue can adapt a bit. And here finally we got also a good result. And so, you know, these are some more common cases, and I think these are the kind of cases you, in your opinion, it's the same, it's very similar to the treatment of a tricuspid valve.
Do you have any additional tips and tricks to add? I mean, Marcus has given us a very detailed step-by-step review of how he performs a bicuspid valve TAVI procedure 1. Have you got any additional points from your own practice?
Yeah, maybe Marcus showed us two very nice examples and very illustrative examples on using balloon expandable devices. And I think that actually in most anatomies, you can also use self-expanding technologies. And if you use self-expanding technologies, it is really important, as you already mentioned, actually, to have an effective predilatation. In most anatomies, it really depends on the amount of calcification that you have. Positioning-wise, I try also when using self-expanding devices to achieve a high position, because but this is actually independent of whether you have a tricuspid or bicuspid aortic valve. With most devices, what you can achieve with a higher position is that you have a better competence, you have less PVL, and you may reduce substantially, independent of the device that you used, rate of conduction disturbances. So I try to achieve a higher position. But you know, there are some reports of having a supra-annular positioning, which in some rare cases can result in a good outcome. But I've also seen embolizations. So I think one should be careful to have a too high positioning.
Sure. I mean, a very important point that we're all making, I think, is that also given that the height of deployment in bicuspid valve anatomy is particularly important, that you should be using a device that you are very comfortable and familiar with.
Oh yeah, this is
one that you know that you can land on the spot very accurately and consistently day in, day out. So that the device that you're most comfortable with is probably the one that you should stick with when you're doing more challenging cases. Would you agree with that general message, Marcus?
Yes, I fully agree with this. And once again, high positioning is really also one key point. But when you use a supra-annular device and you place it high, then what's in the future with the coronary access? So that's always my concern.
Yeah, this is an important aspect.
What about advances in skirt technology, Marcus?
Yeah, perhaps I show the last case, because the last case is a case done with the SAPIEN Ultra valve. SAPIEN Ultra in the smaller sizes 20, 23 and 26 has an as high skirt as the 29 valve. 29 valve is still the same. So, and the higher skirt in fact is very effective in sealing. And here it is a 25.5 annulus, 26 SAPIEN Ultra, also implanted high as possible, as you see here. And then you see the high position here and the functional results. So I think in the future, sure, there are even better techniques or devices available, and it's not the end of the story of treatment of bicuspid valves.
And this patient with a mitral ring, you'll be bringing back for a transeptal
So we know that it's now approved also in Europe for in mitral position.
Yeah,
Yes.
maybe one day in the future. So Marcus, it's very good of you to share all these practical tips and tricks from your high volume practice. And just tell us about a nice paper that you produced for the community recently. I think it's on the next slide, or
perhaps
no?
over. Oh, so it's gone. So we published papers, tips and tricks paper in European Heart for the one who want to read about this, and also we published a sizing paper for this problem of type 0 bicuspid valves in CCI, I think, and so. Yes.
Okay, so maybe with your permission, we could tag that reference to this webinar for our participants to.
I would be happy
to read in the future, because it contains a lot of detailed information that we haven't been able to cover today. I do need to go back to one point, and I'll answer the question directly. But one of our colleagues was still a little bit unclear about the intercommissural distance and the 4 millimeters. But just to clarify for you, whoever is out there, that this is a supra-annular measurement.
Exactly.
And it's 4 millimeters above the aortic annular plane, just for that clarification.
Yep.
So we're going to just do a summary now in terms of the take-home messages of our discussions today. It's been very enjoyable talking to you both, and I've learned a lot as we've gone through the detailed structure of this webinar. But the important point, firstly, to remember is that bicuspid aortic valve anatomy is coming your way, because this anatomical pattern is more and more common in younger patients, and is going to be very much part of our TAVI practice in the years to come. Maybe 10 or even 20% of our cases will have bicuspid aortic valves as time goes by. The conversations that we've had with Juan have very clearly demonstrated that the CT scan is fundamentally important in demonstrating the bicuspid anatomy in diagnostic terms, but also providing very sophisticated levels of detail regarding the patterns of fusion, which, as Marcus has told us, will have a direct impact on the planning of your procedure, but also telling us more about the bulk of calcification on the aortic valve leaflets, the potential risks to the coronary arteries at the time of valve implantation, and also, of course, telling us about the ascending aorta. Is there an aneurysm, and surgery may be a better option in some patients? And something that we haven't focused on in great detail, the iliofemoral anatomy and its tortuosity and its suitability for transfemoral access. And finally, with the help of Marcus's nice teaching cases, we realise that the procedural steps can be quite challenging. There's a need for an increased repertoire of crossing catheters, to use a balloon for pre-sizing in many cases and pre-dilatation, particularly if you're using a self-expanding valve. And these very careful steps of attention to detail are fundamentally important to achieve the best outcomes for our patients. So thank you for joining us in this webinar. Thank you to Edwards Life Sciences for providing support with the logistics. I hope it's been instructive and educational for you, and I thank you for joining us.